transplant, then when that transplant fails, they've got all of their veins left for hemodialysis in the future. Moreover, PD is a well-tolerated treatment. I've got a handful of young women, and it does tend to be young women for some reason, who on hemodialysis, they don't feel well at all. They've got terrible headaches, they get nausea, they've got all these symptoms of low-grade disequilibrium, and I do everything I can to get them better. They're a little bit better, but when I move them to PD, they feel tons better. They're at home, they're empowered, but also their physical symptoms have improved. And we know that heart failure benefits from PD treatment, and that cognitive impairment accelerates more slowly with PD rather than hemodialysis. And I apologize to Professor Brown for quoting her own conclusions back to her. So this is Carol. She was our single-handed PD sister for 25 years and a really very good nurse. But by the end of her career became, I think, very tired because she'd always been just single-handed. And we'd never put more nurses in to help her, and she would sometimes say, oh, no, don't give me another patient, I can't deal with it. So, of course, the service couldn't grow, and we didn't do her any service, but with her retirement became an opportunity to move things forward further. So I'm going to divide the rest of the talk into recruitment, keeping on track, and minimizing drop-off. I spoke to our nurses who did education, and they said, my job is to give information neutrally. I'm not going to persuade anyone to do PD for you. I'm not going to help you to grow your service. I'm just going to give the information neutrally. The patient will decide. But they don't do that because they say, oh, PD, you've got to be very careful hand hygiene. You might get peritonitis. The catheter might not work. You've got to keep your bowels regular, all these things. Or you can do hemodialysis. You come into hospital, we'll do everything for you, you go home afterwards. It's not neutral information. Instead, I wanted them to share the insights. You know what our patients complain about with hemodialysis is that transport into why someone might choose hemo rather than PD and challenge anything that they got the wrong end of the stick over. So I changed I changed patient education to group sessions so that I could have a bit more oversight, but also to bring in more members of staff so each nurse who had specialist interest could teach directly on her specialist interest. So here we've got home hemo specialist nurse, PD specialist nurse. We've got videos playing in the background. We've got equipment at the front of the room where patients can have hands-on. So those people who say, oh, I won't be able to do it, I've got arthritis, well, come to the front and let's see if we can do it or not. And often they can. We have very simple ways of explaining how PD works, something close to all of our heart, the tea bag, and simple ways of explaining how different regimes of peritoneal dialysis might be performed. We address cosmesis head-on, and for some patients, actually a tube coming out of their abdomen, and we call it a tube, not a catheter, because a catheter sounds like something that comes out of your genitals to our patients. They prefer that word, and they're happy that something's coming out of their abdomen rather than something on their arm. We're lucky in the UK because we have residential training centres, so we sometimes train our patients at home, but that takes 3 or 4 days of our nurses' time, or we can send them in a group to a regional centre where they stay for the week and get trained. They come back to us fully trained with a really good knowledge. So we're selling this positive view of peritoneal dialysis. Patients still have fears. I'll be on my own, what happens if something goes wrong? And we just reassure them, if it goes wrong, if the machine breaks in the middle of the night or something goes wrong, we show you how to finish your treatment safely. You phone us in the morning and we'll fix things for you. And we have to address family concerns because sometimes they're the rate limiting step. Oh, I think Dad won't be able to cope with this. Well, Dad's still driving, he's still completely independent. I think he'll be able to do this. And I say, if you can put petrol in a car, if you can handle a flammable hydrocarbon and pump it at several litres a minute, probably you can connect yourself to a peritoneal dialysis catheter without causing mass destruction. So there are many myths that people seem to come out of the womb with, and we just need to challenge these as well. My favourite being, I've got a cat, I can't possibly do peritoneal dialysis. But that came from one of my nurses. They told the patient that. So we keep promoting. We have these camper vans, they come to the hospital, we put our patients in them doing their dialysis, one doing PD, one doing home hemo, just to show how flexible this treatment is, how people can travel with it, how people can do it anywhere. They can do it on a boat, they can do it in the countryside, and as the last speaker said, it doesn't rely on power, it doesn't rely on infrastructure particularly. So what happened by changing that education? Well, we got closer to that expected binary response. Our about half of patients chose PD. Great, now we just have to deliver on it. But they got a sense of positivity from that message as well. I've got options, they've got a plan for me. There's a standardized approach of how we're going to do this. And of course, you keep recruiting. Just because they chose hemodialysis, their fistula fails. Have you thought about PD? You now know some of the realities of hemodialysis. What about doing PD now? The home visit, I think, is important. So get staff right in setting up a service, but do a home visit and just make sure that it's going to work where this patient is living. I've had a few people in my city where we've rushed them through, and they've said, oh yeah, the house is fine. But then when we've gone to do deliveries, actually found it's actually frankly squalid, and even with the most proactive nurse saying, I will find a space, even if it's 2 square meters in the corner of a bedroom, I will find a clean space where they can do it. And she's come back to me and said, no, I really can't do it this time. We've still got those patients on PD, but we've had to sort out their house and stuff before we could do it. So reinventing the wheel continues. And I moved down the coast to Hartlepool, which is the next town south of Sunderland, which is where I live, and I found that another boat has made itself into Pakistani ownership, and it only lasted 7 years in your service as well. So I'm not sure if this is a deliberate act of destruction from the Pakistanis towards our shipbuilding, or whether it reflects our shipbuilding, but there we go. So staffing, absolutely the most important thing, and I have a senior nurse, kind of a normal staff nurse and a healthcare assistant for our patients. It means that we can robustly look after our patients. I think start with 2 individuals, one who's really going to own that role, really going to deliver it, really identifies with that, has that knowledge base. Yes, you will have to train them yourself, but get them an assistant as well. But don't forget to educate and support the rest of the team, and have support there which is again standardized. So if a patient comes to the ward in the middle of the night, or they phone the ward in the middle of the night, that nurse needs to know they're inserted, either medically or laparoscopically, and then how to train the patient and how to deal with any complications. But I've just highlighted the first few steps. When the patient comes to see the surgeon or comes to see me as an interventional nephrologist, I need to remember a few things. They've got to sign a consent form, they've got to have a pre-assessment clinic, they've got to be measured and marked, they've got to get some laxatives so that they avoid constipation, they've got to have skin decolonization. If I don't write all that stuff down, something's going to get forgotten, outcomes will drop. So standardize the whole process. And of course, the ISPD guidelines, as Professor Finkelstein said this morning, are very comprehensive and can be readily adapted to provide local solutions. Other small innovations, catheter designs are different. They come in different lengths for different sizes of patients. You can have an exit site up here on the chest wall if you need to, if you're worried about an exit site on the abdomen. It's a very obese patient with skin folds, etc. You can get a longer design of catheter. So having that in the repertory means that we're more likely to have more patients on dialysis successfully. I think the thing that I'm most pleased about doing is having the transition clinic. So this was pre-dialysis patients, but I moved them out of the low clearance patients where people were still talking about hemodialysis, and I took them where they were only ever going to meet peritoneal dialysis patients and me, and I was only going to talk handling, exit site care. Even before their buried catheter was externalized, we could do this on the models. But also, touching on Professor Brown's talk yesterday on palliative care, I could have advanced care planning to order. They're only for ward ceiling of care. They would or would not accept this level of treatment if they come in acutely unwell in the middle of the night. Training and retraining. Before, we trained the patient and then we wished them on their way, and then we dealt with any complications. But we really need to retrain, so we started retraining. We brought them back for just a one-day top-up 6 weeks after they started training, just to pick up any bad habits that had developed. We retrain after any episodes of catheter-related infection, and we retrain at least annually thereafter. We also have drop-in training sessions where they can come and have more training. Once they move to a PD clinic, and you see I've just standardized it, so they go low clearance, transition clinic, PD clinic, and it just is a mental trigger for me to address all of the subtle medication changes that can make PD more effective. I think they all need to be on big doses of diuretics. Most of the patients have got heart failure. I may not have been able to maximally titrate an ACE inhibitor before they started dialysis, but now I can. Maybe I can get the angio, and fair enough, that will give their residual kidney function a contrast hit, but it might stop them dying of ischemic heart disease. And I'm giving them glucose, so I need buy-in from the diabetes team if I can't get optimal HbA1c control at this point. Quality assurance. So again, the bulk of this slide is from ISPD suggested audit standards. And that includes everything from adequacy and PET tests to looking at catheter function. I would add to that, as well as infection rates, if you are reliant on surgeons, try to audit how long it takes them to respond to your request. If you're doing buried catheters, you've got flexibility. If you need a catheter urgently, then you need to know how long that's going to take. But my bugbear is the catheter that migrates out of the pelvis and is trying to drain dialysis fluid from near the liver, and that just doesn't work very well. So I need to either be able to manipulate that wire with a stiff guide wire back into the pelvis. That's actually really difficult to do. Or we just put in a new catheter, which is fine, but we might fail. Or I need a surgeon to laparoscopically drag that catheter back to the pelvis and suture it into place. And it's no good to me if that surgeon will offer me a date in 2 weeks' time. I need it now because I don't want my patient going to hemodialysis. I want them staying on PD. So there is good drop-off. Transplantation, that's probably, hopefully, going to be our biggest cause of moving away from peritoneal dialysis. But even unavoidable death, if I've done everything I could have done to prevent it, that's okay as well. But the dysfunction of catheters is a drop-off that we don't want, but it's common. So we just need a robust policy of what we're going to do, how we're going to deal with it, who is going to be involved. So you don't have to improvise a solution. It will be a different solution here than it is for me, probably. It needs to be a local solution, and I'm afraid I don't have all of the answers, even at home, let alone here. But there just needs to be a considered policy. So it's just routine. UF failure, sometimes it is genuine membrane failure. Sometimes it's just failure to educate the patient on adequate fluid restriction. Fine, when they first start PD, they may UF quite nicely, and they're still peeing just as much as they were yesterday before they started dialysis. But 6 months down the line, their fluid restriction needs to be stricter, but we haven't told them that. We didn't maximize their diuretics. What's great about PD is the potassium tends to be very well controlled, so I can often get my patients on spironolactone or eplerenone for heart failure outcomes, but also to augment diuresis. And if possible, the use of biocompatible fluids and the use of low glucose fluids to try and engender longevity from the peritoneal membrane is a nice thing to do. So particularly for my diabetic patients, I try to just maximize their diuretics, put them on Neutronil and icodextrin, and minimize their glucose loading at all, at least in the early stages. That tends to work. Infection I'm going to gloss over because you'll hear from it with far more authority from Professor Brown later. Suffice to say the word standardized is still in there. And burnout is something which I think is important to consider. Patients who are looking after themselves at home are taking on a significant responsibility, and that responsibility is every day of their life. It may not just be them, it may also be their family, and they get to a point where they feel exhausted from doing dialysis. And we need to have ways of sensibly de-intensifying their treatment regime at points when they are tired. And I very proactively say to them, at some point you're going to get tired. Please don't get fed up and just come to hemodialysis instead. Tell me, and we'll look together and see, can you have a weekend off every 2 weeks? Can you go to 5 nights a week instead of 7 nights a week? Can you do 3 exchanges a day rather than 4? What is the solution that's going to work for you that will make you be able to continue peritoneal dialysis for longer? And of course, sometimes we'll need to involve other people. Sometimes you do need to move the patient to hemo. If you're going to try and get them back to PD, don't give them to a hemodialysis doctor. It's easy for me. I look after a third of our hemo patients as well. Keep them in the PD clinic. Keep them belonging to you. Yes, you're having hemodialysis now, but you're a PD patient. We're going to get that catheter back in, and you're going to stay on PD. As an interventional nephrologist, obviously I'm going to say that it's great if we can do these, and I think for the reasons outlined in the last talk, percutaneous PD catheter insertion by nephrologists is a great idea. So coming to the end of it, and having tried to reinvent the wheel with all of the cartoons I could find on Google, in summary, these are my key points. I think education and promotion ruthlessly. This is a great therapy. And if we're not seeing 50% of our patients choosing it, we're not selling it adequately, and we're not giving the potential benefits to our patients. But we need that message to come consistently from all of our colleagues, from all of our nurses, everyone who has contact, because the patient comes in and the nurse says, oh yeah, not many people choose PD. Most of our patients choose hemo. Oh, that's just undone loads of work that I've done to try and build up PD in their minds. I like the transition clinic idea. It might work here, it might not work here. but grow the staff as you grow your patient numbers. Have a standardized approach to everything and keep hold of the patients whenever they need to disappear temporarily to hemodialysis. Those are my thoughts, but I'm very welcome to receive any feedback or tips because I am still learning. So far, my numbers have gone from 18. This has taken some time to implement. It's been in process for about the last 3 or 4 months, and that time we've gone from 18 to 32 patients. We've got more staff in. I hope that I'm going to see this grow further. Fingers crossed. Thank you very much.
Dr. Ali Raza is the Clinical Assistant Professor and Head of Nephrology Section, Department of Medicine at Aga Khan University Hospital. He is Diplomat, American Board of Medicine and Nephrology. He has done his fellowship in interventional nephrology as well as training in vascular accesses at Illinois. He is a Fellow of American Society of Nephrology as well as American Society of Diagnostic and Interventional Nephrology. He is going to talk about PD catheter insertions technique by a nephrologist. Please.
Assalamu alaikum and good afternoon. Thank you for the introduction. So in these 20 minutes, 25 minutes, I'll try to convince everyone that PD catheters are very easy to place, and they should be placed ideally by people who are taking care of these PD patients, that is the nephrologist. So basically, PD catheter is a functional cutaneous-peritoneal fistula. It is a conduit between the outside of the body to the intraperitoneal space. So that's how we define it. And as you know, the burden of RRT is increasing everywhere. I found this slide that shows that PD has been increasing in certain parts of the world, especially in our region. But unfortunately, in Pakistan, it remains lower on the ring. So what we need to do is increase awareness. We need to tell patients that it gives ease of access and mobility, and it's certainly cheaper. This is an old slide from US, and it shows that a lot of people switch from hemodialysis to PD, and the two most common reasons are infection and catheter-related problems. So it is very important for the nephrologist to be involved in the insertion of the PD catheters. So this is going to be my roadmap for the talk. I'm going to talk a little bit about the design of the PD catheters, placement issues, who should be placing these, what are the technical issues that we encounter, and also some management issues at the start of PD and how we can avoid temporary hemodialysis catheters and start patients on PD, what we call early start PD. So the design of the catheter should be such that it reduces the risk of catheter-related complications and reduces the risk of transfer to hemodialysis. These are some of the common complications, and they will be discussed further later. But mechanical complications, obviously, if you can't perform an exchange, it's inadequate hydraulic function. Mental entrapment is very common. Leaks can happen with improper placement. And infections obviously remain another big part of PD failure, especially exit site tunnel and peritonitis. So what are the catheters usually made out of? So currently what we have right now, most of the catheters that we use are made out of silicone. There were some polyurethane catheters, but they had some issues with integrity, especially with exit site antibiotics. It caused damage to polyurethane, and you would see the catheter site would get opacified, and there would be leak around the catheters as well, and sometimes they would break off and rupture as well. So I don't use polyurethane catheters. We have silicone-based catheters usually. So the catheter design is very straightforward, simple, and most people know there are three parts to it. There is an external segment, which is obviously outside the skin. And there is a tunnel segment, which is in the subcutaneous tissue, and part of it is in the muscle, the rectus muscle. And then there is the intraperitoneal space, which has the intraperitoneal catheter. Again, the same thing, external segment, tunnel segment, and intraperitoneal segment as I described. And these are some of the designs that we have. People keep asking me, do you put swan neck catheters or do you put, something else? So it depends on the patient. If you are looking for a tunnel that is lower down in the abdomen, you would go with a swan neck. If the patient needs exit site to be on the outside laterally, like Dr. Clark mentioned, obese patients sometimes need even chest catheters all the way up to the front of the chest, the tunnel site is there. So it depends on the patient characteristic that we decide how and when and what type of catheter we are going to place. And I'll show you some of the examples later. So starting with the external segment, as I said, the external segment is the part of the catheter that the patient will be using for dialysis. So it has to be visible. And depending on the patient's size and anatomy, we decide the exit site. So if the patient is obese, have a big abdomen, if you put the catheter in the lower abdomen below the pannus, it will not be easily visible for them. So ideally, those catheters should be laterally up, above the umbilicus on the outside, so that they can easily do catheter care. On the other hand, if a patient is lean and they don't have any of issues with the large abdomen, and I'll show you some of the examples with belt line, then we can put the catheter in the lower abdomen as well, and they should be able to handle it without any problems. And another disclosure, this is my way of doing a catheter. There are different ways, and we'll talk about them briefly, but this is how I, as an interventional nephrologist, put these catheters in. So again, as I said, the exit site should be placed in the lower abdomen, and at that time, you should use a swan neck catheter, and that avoids the migration of the catheter, especially there should not be any stress on the exit side of the catheter. And if you're placing the catheter on the lateral side, outside, a straight catheter can be used. So tunnel segment, again, the part that is under the skin, between the skin and the intraperitoneal space is the tunnel segment. And it again comes in different flavors. It can be a straight segment, it can be a curved segment, it can have one cuff, it can have two cuffs. So there are a lot of designs, but the way I was trained, we use two cuff catheters. They are better secured because one cuff is in the rectus muscle, the other one is in the subcutaneous tissue. And I use both straight and swan neck catheter, again, based on patient's anatomy. Same thing, again, there are catheters that have even three cuffs, but I have not used them. There are catheters that have only one cuff, and these are CAPD catheters, not acute PD catheters. There's no controlled data, as far as I'm aware of, that sheds light on one catheter being better than the other. But as I said, when I was training, I was repeatedly told, and we saw this as well, that when you have one cuff that is in the rectus muscle, the catheter is much more firmer, the anchor is much better, and it doesn't migrate, it doesn't get pulled out that easily. Sorry for the picture, but now we'll come to the intraperitoneal segment. Again, there are different varieties. It can be a straight, like as you can see, the Tankoff, but the more favored one is the coil Tankoff catheter, and that's what we prefer to use. There is the Toronto Western Hospital catheter with silicone discs. They have some data on it, but all these catheters are made so that the jetting effect of the fluid is minimized. And then there's the Ash T fluted catheter. I have not used it, but it's there. So main thing is to provide enough space and enough holes on the side of these catheters so that the fluid can be easily put in the interperitoneal cavity. And again, there is no data to suggest, actually there is a little bit of a data on coiled versus straight intraperitoneal catheters from Australia that shows that straight catheters that were used intraperitoneally saw more transfer from PD to hemodialysis, but the numbers were very small, and there is no biological plausibility of this. I mean, but again, it depends on what catheter is available. In our practice, we usually have coiled catheters, and intraperitoneal segment is coiled, so that's what we use, and we have had good success. So coming to the technical issues, how do we put these catheters in? Again, there are many techniques, and I am not an expert on the surgical techniques, but I will tell you what I do in my practice, using fluoroscopy and ultrasound guidance to put in these catheters. And believe me, these are very easy to put in. This is not rocket science. Anyone who can operate an ultrasound machine and have 2 legs to use the fluoroscope can put these catheters in without any problems. So some of the things that we look at before we put the catheters in is pre-operative antibiotics prophylaxis. ISPD guidelines recommend that we should give pre-operative antibiotics before the catheter, and depends on the local susceptibility of the organisms and what organisms are usually available or prevalent, sorry. And there is data that vancomycin has been shown to be more effective in preventing peritonitis 30 days post-insertion compared to other antibiotics. But as you know, vancomycin is expensive, as well as we don't want to use it on patients that are naive to infections to prevent further resistance to this antibiotic. So in our practice, we use first or second generation cephalosporins. We give 1 dose prior to the insertion, and this is based on ISPD recommendations. Again, I'll show you some of the location and how I choose the location of the catheter tip, placement of the deep cuff, and then placement of the exit site. I think this is the most important thing that I found over years of putting in these catheters, that has to be appropriately done, and I'll show you how I do it in my practice. So again, I keep emphasizing, very important that the whole nephrology team is involved in placement of these catheters, and as Dr. Clark also mentioned, it involves the nephrologists, the nursing staff, and even the social workers. Everyone should be involved in placement of these catheters, because patient has to be educated about how to take care of these catheters, what to do if there's a problem. The other thing is that preoperative marking of the abdomen for catheter placement is very, very important, because if you mark these catheters using stencils, it makes it very easy to place them when the patient is on the table. And we usually do it, and the way I was trained was to do it standing up, and then we lay the patient down and see where those marks are once they are supine position. What we mark is the location of the deep cuff, and that's where we enter the abdomen. Location of the superficial cuff is marked as well on the abdomen, and we gauge where the location of the exit site will be based on the location of the superficial and deep cuff. So as you can see, most of these catheters come with stencils. You can make your own stencil. You can use a catheter that is not used as a stencil as well. And if you properly do it, you would avoid these entrapment of the omentum, because most of the catheters that are not properly placed are in the upper abdomen. The proper place is the pelvic area, and that corresponds to the pubic symphysis, as you can see when you're marking. So the coil or the tip of the catheter should be at the level of the pubic symphysis. when you're marking the exit site and the deep cuff. So again, it's very straightforward, simple to do. Pre-operatively, you stand the patient up, you put the catheter or the stencil right where you want it at the pubic symphysis. The tip should be there, and then from there on, you can mark the entry and the exit sites. Coming to the deep cuff, there are different variations on what could be done. Some people anchor it into the muscle. Some people leave it in the subcutaneous tissue. What I do is I use a peel-away sheath, and I make sure that my catheter, the deep cuff, is pushed in to the muscle. And sometimes you have to do a little bit of dissection using the hemostat to make a little bit of an opening, because it's not easy to push that Dacron cuff into the peritoneal cavity or close to the peritoneal cavity. But with a peel-away sheath, it's very easy, because by the time you dilate with using the peel-away sheath, the size of the hole is such that the catheter, the cuff usually goes in. I don't put sutures, and some people do purse string sutures. I don't do it. I've had no issues as long as the exit site is not under stress. So as you can see in this picture, this is the ideal place. The deep cuff should be in the muscle of the abdomen. So again, told you what I do with the deep cuff, and the entry point again should be paramedian. If we used to do midline, entry points. The issue is if you go through the linea alba, it's a very collagenous space, and it doesn't close around the deep cuff. So we stopped doing those. I do a paramedian insertion point and go through the muscle. Because if you go through the linea alba, the leak, the peritoneal catheter can leak very easily. So now coming to the exit site, I think the most important, especially for the patient as well. So the best practices should be away, the exit site should be away from the belt line. And believe it or not, everyone has a different belt line. Some people have belt lines below, like I have, below the umbilicus. Some people have belt lines above the umbilicus. So you have to find out from the patient where they have they tie their belts or their, pajamas or whatever, so that you are away from that area, for the exit site. It should be clearly visible. It should be inserted through the abdominal wall with least amount of stress tubing. As I said, it should not be pulling, or the catheter should not be pulling out of the exit site. And it should be about 1 inch from the superficial cuff, and I'll show you how we do that. And as I said, marking in the supine position and upright position helps with knowing exactly where your exit site would be. So the rule of thumb is if your belt line is above the umbilicus, you put the catheter, the exit site below the umbilicus. And in those cases, we use the swan neck catheters because it's easy and it's turned downwards. And if your belt line is below the umbilicus, the exit site should be above and laterally, and that's easily done with a straight catheter. And that's my practice. I mean, again, it is no guidelines on it, but this is how I was trained. This is a picture I would refer to. You can see in this patient, one patient, the belt line is above the umbilicus, so the catheter exit site is below, and on the other side, it's laterally because the belt line is below the umbilicus. And again, visibility of access is important because patients have to do daily care of the exit site. They have to be able to look at the catheter, make sure there is no oozing, no discharge. They need to clean the catheter. So it's very important that they can see where the exit site is. So this is an example. As you can see, this is on the right side. The patient has a big protuberant abdomen. And when the pannus is falling down and he's sitting, you can't see the catheter. And even with 2 hands, it's very difficult for him to see this catheter. On the right side, similar patient, the exit site is appropriate place, either on the upper part of the abdomen away from the umbilicus, or you can do a chest catheter. which needs an extension tubing, but it's easily done and very simple for patients to manage. Again, same thing, it is a dilemma for obese patients, unfortunately, so we have to make sure that they're able to see their exit sites and perform catheter care very easily. So exit site from superficial cuff, when I mark the exit site in relation to the superficial cuff, I make sure it's about an inch from the inch distal to the superficial cuff. Because if it's not, you can have easily, extrusion of the catheter superficial cuff out of the exit site, and then it becomes a problem. Infection and other things can happen. So this is how I mark my patients. We do it standing up first. Very simple, very easy to do. You can use a catheter that is extra, or there are stencils that most catheters come with. And so first you place the coil or the coil area around the pubic symphysis area, and that's your target area where you're trying to keep the catheter tip. And then from there on, paramedian area, you go up and you mark the deep cuff, which is the insertion site where you're going to make the puncture into the abdomen. And from there, you can see on the middle picture, you can easily mark the superficial cuff, and you can decide if you want to do whatever angle you want to go. But what I try to do is I don't try to go too acutely with the angle, because unless it's a swan neck catheter, if you try to bend down the superficial cuff or go lower down, you can kink the catheter as well, and it becomes a problem. So again, pre-operative marking is essential in my practice, and we usually use a stencil that is provided in the catheter. If you don't have that, you can easily make one yourself. It's very easy to do. So in summary, marking the abdomen should be marked with the patient standing as well as recumbent position. Location of the incision of the peritoneal cavity should be identified and marked. It should be a paramedian incision, not in the midline, because you don't want to go in through the linea alba. And the exit site should be within an inch from the superficial cuff. So I don't put any sutures at the exit site because it causes infection, other problems, and it should not be a very big patulous exit site. So what I do is when I'm tunneling the catheter out for the exit site, I make a very small incision, not a large, big incision, very small incisions, just so that the tunneling device can go through easily through the abdomen. And I don't make large incisions or sutures and things like that. So that helps with healing, and that helps prevent infection as well as catheter migration as well. So how should PD catheters be placed? So in my opinion, they should be placed so there are two ways of doing it. Blindly, where you just go in and you put a PD catheter, the Seldinger technique. But in fluoroscopy, you can visualize where your tip is. You can visualize, you can inject a little bit of contrast into the abdomen, make sure there are no leaks. There are no punctures of the gut. So in my opinion, that's the best way to do it. You are visualizing the abdomen, the abdominal wall, and everything. And then there is direct visualization. There is something called a peritonioscope, which was invented by a surgeon, and it's specifically made it's like a mini laparoscope, but it's very expensive. So I have not used it, but people do use it in the West. I don't think we have one here. You can do open surgical dissection. I would say that it should not be done unless there is good reason for it, if you're repairing the hernias and things like that. And laparoscopic, which is the preferred surgical way of doing it, and it can be done under local anesthesia. And who should be doing these catheters? I would say surgeons, obviously, but nephrologists, especially interventional nephrologists, should be doing these more and more. And obviously IR, guys can do it as well. So timing of placement. So I wait at least, if I could, 2 weeks before I start using the catheter. That's been shown to reduce leaks and other problems. Initial and periodic flushing of the catheter is needed during the break-in period. If some patients who are post-transplant or they have healing issues, the break-in period may be longer. If you implant the catheter too early, meaning patient still not on dialysis, you need to care for the catheter longer. And if you do it too late, then you have a shorter break-in period. So that's something we need to figure out ahead of time. So early break-in period, as I said, sometimes you have to start PD early. You can do it. It's been done within 1 or 2 days, but the risk is pericatheter leak. And so the solution is you lay the patient down every time they're doing exchanges, and you do very small, a liter exchange in supine position. In that way, you can provide some clearance, but it's not adequate dialysis, and obviously it cannot be done at home. It has to be done under supervision most of the time. So we try to avoid this, but sometimes it needs to be done. I'll quickly go through embedded catheters. I don't do those, but they're done for various reasons, because once you embed a catheter, you can leave it in till the patient needs it for dialysis, and it's successful. It's easily exteriorized, and it can be used without any problems. The initial rationale was biofilm, that if the catheter is extending outwards, it will form a biofilm if it's not being used. So just bury it and leave it in. But right now we are doing it for catheters that are placed right after patient decides the modality of dialysis, so they don't have to guess, or we don't have to guess the timing of the catheter placement, and can be exteriorized on the day of starting PD. So it's very safe and easily done. And these are some data that shows that its exteriorization works very well. Only, I think, less than 10% catheters don't function right away, and they can be also made to work after flushing with heparin, and sometimes using a stylet to move the catheter a little bit. And that's my talk. Thank you. Any questions?
Thank you very much, Dr. Ali Raza. Now we are going to have Professor Edwina Brown. She is an eminent scholar, a consultant nephrologist at Imperial College Renal and Transplant Center, Hammersmith Hospital, London, honorary professor of renal medicine, Imperial College London. Her main clinical and educational interests are peritoneal dialysis, dialysis in elderly, and renal supportive care. She is the principal investigator for FIPOD. She has published extensively on peritoneal dialysis and dialysis in elderly, and is the author, auditor on several books. She is an honorary fellow of the British Renal Society and of the European Renal Association. She is the chair of Guidelines Committee of the International Society of Peritoneal Dialysis. She is going to educate us on peritonitis and its prevention. Professor Brown, please.
Thank you very much for the introduction, and thanks once again to PSN for inviting me to come here and talk. I've really enjoyed my time in Pakistan, and I find the enthusiasm for getting peritoneal dialysis restarted in this country really rewarding, and I wish you the best of luck. And we are here, the experts elsewhere and the International Society of Peritoneal Dialysis to help you in that venture. So moving on to peritonitis, we've already heard this morning as to how one of the reasons that PD has not really been generally accepted is the fear of infection. And it is a really important part of setting up any PD program is to have robust protocols in place so that everybody is from the same page, as it were, and so you can manage these infections. And these protocols should be based on the guidelines which have been produced by the ISPD. So this is the most recent one on infection prevention and treatment, for Peritonitis, which was published in 2016. So we're going to be talking about the various definitions of different types of infection, management and prevention. So this is a very old slide that I think I stole from Ram Gokal, who is one of the doyens of peritoneal dialysis, worked in Manchester in the UK, and really shows the various parts of PD, or the process of PD, where infection can be introduced. And many of these we can do something about. We can certainly, with modern connections that exist, it's not just the process of producing fluid, it's also having the connectors and the lines, etc. We certainly don't want, number one, the infection from the exchange procedure, and we no longer put spikes into bags. So that's one thing that has been obliterated in the last 20 years. You then need to think about the sort of connector number 2 there, where you connect the bag to the catheter, and the catheter, so the mini set line that lines between the bag tubing and the catheter. And again, your procedures for changing that tubing need to be very robust. And again, all of this is in the guidelines. Patients need to be trained how not to get infection around their exit site. But there is very little that we can do about transcolonic spread or hematogenous. So there's always going to be some things that are causing infection that are very hard to produce. So infection is going to happen in people on peritoneal dialysis, but remember, infections also occur in people on hemodialysis, particularly if they've got necklines. So the definition of peritonitis is having 2 of these 3 components: abdominal pain or tenderness, cloudy fluid with greater than 100 white cells per mil, with over 50% of those being neutrophils, and identification of the organism. And since identification of the organism is going to take some time in clinical practice, it's numbers 1 and 2. And as I explained in the workshop on Friday, you do not need to wait until you get the microscopy back to start antibiotics. If somebody has got really cloudy fluid, just get on and give the antibiotics. So this is the key part of all of this is getting the patient to recognize the cloudy bag. And part of the training process is teaching them that and telling them what to do when they get the cloudy bag. So we train our patients to put a bit of newspaper underneath the bag when they're draining, and if they can read the printed page, then through the bag, then that fluid is clear. If they can't, it's cloudy. So peritonitis is a major cause of morbidity. It has an impact on quality of life. It interrupts the usual routine for the patient, who now has to frequently come up to the hospital. It is associated with mortality, though this is very infrequent and certainly much lower than if you get infections related to central venous catheters. It remains a major cause of technique failure. It does contribute to changes in membrane permeability, and we need to remember that exit site infections can lead to catheter loss and peritonitis. So these are the audit standards for peritonitis from the ISPD, which is 0.5 episodes per year at risk, or 1 episode for 24 patient months. The UK Renal Association is very similar, with a primary cure rate of greater than 80% and a culture negative rate of less than 20%. Having said that that is the audit standard, actually in many countries, as we've heard from previous talks this morning, are much lower than that. And that includes countries which have a PD first policy, so they're putting on patients who may not have started PD in other countries, and they're often very hot, humid countries like Pakistan. And I don't have a slide to show it, because it's not been published yet, but it has been presented at meetings, the infection rates that have come through the PDOP study, which looks at 6 different countries, which are UK, US, Japan, Thailand, Australia, and Canada. And actually the country with the highest infection rate, I regret to say, is the UK, and Thailand has a very much lower infection rate than we do. So yes, you can get low rates of peritonitis in low-resource countries with hot, humid weather. So this is the terminology that rather confuses the field of peritonitis, but it is important to know. So recurrent peritonitis is that which occurs within 4 weeks, but with a different organism. Relapsing peritonitis is within 4 weeks with the same organism. And repeat peritonitis is when you get the same organism but more than 4 weeks away. And the reason that's important is that the relapsing and the repeat peritonitis implies that you've got a biofilm and that you should be exchanging the catheter. So it was recognized very early on. This is a paper that Simon Davis published 20 years ago, showing that peritonitis was a major cause of technique failure. It is still true today. This is the ANS data registry, so this is from Australia, showing that infection was causing 30% of technique failure, and a Canadian study which has shown that the median time to technique failure has not really changed over many decades, and there was no reduction in risk of technique failure due to peritonitis over those time periods. So peritonitis remains important wherever you do peritoneal dialysis, and with careful attention to technique and careful protocols, that can be brought down to very low levels. So in terms of catheter-related infections, the 2 most common are staphylococcal and Pseudomonas, associated with biofilm and exit site problems. Then you have bowel source of organisms, and we heard about how important these are in India. It's causing 60% of peritonitis, and I suspect that may well be related to the high level of diarrhea associated with sort of poor drinking water. So, addressing the diarrhea and waterborne infections that one gets in countries with poor hygiene is going to be really important to have a successful PD program. It is important to mention culture-negative peritonitis, and this occurs because of poor microbiology. It's not partly due to poor microbiology, and partly because there are other causes, such as recent antibiotic use, delays in getting the sample to the lab, endotoxins, etc. And if you have a culture-negative peritonitis, does not mean that you don't have an infection. You should still treat them as a bacterial infection. So in terms of management, you start with the cloudy dialysate. The patient has to get to somewhere, and we went through different strategies in the workshop. You need to then get a fluid sample by a nurse, who then sends it to the microbiology lab. Ideally, the fluid should go into a blood culture bottle, and that's the ISPD recommendation to really increase your return of cultures. Empiric antibiotics must include vancomycin or cephalosporin for a gram-positive, and third-generation cephalosporin or aminoglycoside for a gram-negative. But what you use in your individual centers depends on your microbiology, and this is, again, emphasizes the importance of developing microbiology links when you're setting up a PD program. So, you can put antibiotics into the same bag, which means that you can send patients home with pre-injected bags, or All the dosages are in the ISPD guideline. I cannot remember them off by heart. So, when my nurses ring me up and say, what should we use? We do have them in our protocol that we use. But if it's anything out of the ordinary, then I always check the ISPD guideline, which I have on my phone. In terms of catheter removal, one needs to be able to recognize when an infection is not improving, because the one thing you don't want to do is to leave that catheter in for too long, because you then just get a very sick patient. So you do need to recognize when it's not getting better, and the recommendation is within 5 days. You certainly need to remove the catheter if the peritonitis is associated with a tunnel infection, or if you have patients with chronic exit site infections, particularly those caused by Staph aureus or Pseudomonas. If somebody has a fungal peritonitis, that catheter needs to be removed immediately. And I was asked in the workshops about using antifungal prophylaxis. That is an ISPD recommendation. The PDOPS data shows that most countries don't actually do this. We certainly don't do it in our center, but then I see about one patient with fungal peritonitis every 2 or 3 years. If the Indian experience is replicated in Pakistan, so you get 10% of your infections being fungal peritonitis, then you probably would need to use fungal prophylaxis. And that is for every single time you use antibiotics, not just when you're giving antibiotics for peritonitis. And this is something that you need to think about economically. They're not cheap, the drugs. And you also need to always look at all the other medications the patient is on and adjust the doses. So culture should be available by days 3 to 4. Use the ISPD guidelines to check doses of antibiotics. The recommendation is you only need to give the antibiotics once a day. So you give a high dose and the bag dwells for 6 hours, so you get good systemic absorption. So the antibiotic then diffuses back into the bloodstream until you give another intraperitoneal dose the next day. Vancomycin only needs to be given once a week if no urine output, and every 5 days if there is urine output. You can measure levels, but that's going to be expensive. And I think just the 7 and 5 days is probably enough. If they're culture negative, use vancomycin and ciprofloxacin. That's the ISPD recommendation, but I gather here in Pakistan, ciprofloxacin is rather handed out like sweeties. So again, you need to discuss this with your microbiologists about what regime you're going to be using. So this algorithm here comes from a very useful overview of peritonitis that has just been published in CJSON by Shetto from the Hong Kong group, where they've got 70% of their patients on PD. And this just is a very useful algorithm, and if you're interested in the topic, I suggest you read that paper. It's very useful. Refractory peritonitis we've really covered, and I want to move on to really thinking about prevention. So in terms of prevention of peritonitis, the basic measures of patient education and training, I can't emphasize that enough. The ISPD has a guideline on how to train patients, but obviously you are going to need train your nurses first how to train the patients. And that is an absolutely crucial part of the whole process of avoiding infection. Avoid constipation. Constipation is a big problem in PD, not just in terms of catheter function, but particularly with older patients. If they get constipated, they increase the risk of activating their diverticular disease. That again can predispose to gram-negative infections. It's not just the PD nurses that you need to train. As you've heard earlier from Dr. Clark's talk, their program has got 1 or 2 nurses, and that's all you will have in your units when they first start. But those nurses aren't always around. Patients may come in with their cloudy bag in off-duty hours, middle of the night, Sundays or whatever. So you do need to have other nurses trained in some of the PD techniques. So we have one ward area where we've trained our ward nurses and made sure that at least one nurse is on call every shift who knows how to get cultures from PD bags. So it's not any old nurse who comes and drains out the patient when they present with a cloudy bag. It should be somebody who knows how to do an exchange. And equally, if somebody is admitted and is too sick to do their own bags, if the people are sick and do a bag change when they're not feeling well, that's when they make mistakes and can get peritonitis. So you need to keep your ward nurses trained how to do PD. Your junior staff, your other nephrologists also need to know something about peritoneal dialysis. Hand washing between patients is really important. It was striking in one unit that, units that I have visited in different countries, that sometimes people go straight from one patient to another, and there's no hand gel around. Hand gel's expensive, water and soap's not. So hand washing in between patients is really important. And also you need to detect patient problems out in the community that can predispose, such as depression, which is very important, burnout, which you've already mentioned. If people get burnt out and bored with the procedure, they'll make mistakes. I very rarely have people on 7 days a week PD. I tend to do it 6 days a week, so they get a day off, particularly if the family's involved, because that also gives the family a day off. None of us want to work 7 days a week, so why should families and patients have to do their PD 7 days a week? So it's only if people are completely anuric and get fluid overloaded that I make them do 7 days a week. And obviously having a clean area at home, which can just be a tray. You don't need a separate room, you don't need a separate table, but you do need a clean tray that you can do the exchanges on. So these are the potentially modifiable risk factors, most of these of which we've mentioned. I do need to emphasize connection methodology. That was really from the first slide. If you're going to start making your own fluid for economic reasons, it's not just the fluid, it's also the connections. Patients need retraining sometimes, when they've had an episode of peritonitis, always go over how do they do their exchange. In the first month, they're going to need much more monitoring about how they're doing things than they are later on. So what happens if people are getting recurrent or relapsing peritonitis? So this is quite a useful scheme. So if somebody gets a repeat episode of peritonitis within 4 weeks, if it's a relapse, in other words, it's the same organism, so that's usually a Staph aureus or a coagulase negative staph or a Pseudomonas, you need to consider catheter replacement. If it's a different organism, so that's a recurrence, you need to retrain the patient. If it's more than 4 weeks and it's a repeat episode of peritonitis, so again the same organism, again consider catheter replacement, and afterward, and if they get another infection of a different organism within 6 months, which is the sort of high-risk period after your first episode of peritonitis, retrain them. So in terms of catheter replacement, we do this at one sitting. We usually do this surgically in our own unit, but there are also units with interventional nephrologists or who are more interventional than my colleagues who take the catheter out and put a new one in percutaneously. So what we do is to make sure that they're covered with antibiotics, the same antibiotics as they were on for their infection, take the old catheter out and put the new one in. And that way you can avoid having to introduce a neckline and hemodialysis. So in terms of, I'm going to skip through this so in terms of prevention and treatment, training is really important. There is an ISPD guideline for that. Exit site care is also important, using topical antibiotics cream or ointment. We tend to use mupirocin. Use cleaning agents when you're doing the exit site dressings. There's no evidence that any is better than another. And have protocols for how you treat exit site infections. So this is just the data that shows things like mupirocin works. So this is really, data has been around for a long time. So this was a randomized controlled trial showing that when mupirocin was introduced, the incidence of peritonitis, of Staph aureus peritonitis, just disappeared. So this is an observational study, actually, after the randomized trials, and showed that in clinical practice, your Staph aureus infections just disappeared. And that's certainly the first question I always ask my patients. Are you still using mupirocin if they come in with Staph aureus? And they have always stopped. There was a fear that this caused more gram-negative infections, but that's actually only apparent because now you have more gram-negative infections, but actually their rate and the rate of Pseudomonas infections are completely stable. So in conclusion, infection in PD does result in significant morbidity, interruption to lifestyle and permanent transfer to hemodialysis, but it has a small mortality risk. Infection management by PD units must include treatment protocols, which need to really be, there's absolutely no reason why every single unit starting PD does this independently. This could easily be done by a group of nephrologists who are interested in PD nationally, and then this is shared with other PD units. So there becomes like a Pakistan protocol for managing infection. Repeated education of non-PD nursing and medics is vitally important. Remember, your junior staff turn over, they rotate, nurses come and go. So this is something that the PD team needs to take on to keep this training up to date. Good communication with your microbiology lab and training and retraining of patients regarding infection. So my final message is, first of all, you must know your peritonitis rate. We have a 6-monthly audit when we look at how many infections we've had, what our rate is, and if it's gone up over the last 6 months, we do what's called a root cause analysis to try and work out why has this happened and what can we address. You need to know your local patterns of organisms, so you're using appropriate empirical antibiotics. You need to identify the local risks for peritonitis, and this is going to come out of your 6-monthly audit, both unit-related and patient-related. And you need to identify a strategy to reduce these risks. And if you do all these things, PD, you can really drive down your infection rate and make PD a very acceptable modality. Thank you.
Thank you, Professor Brown, for the impressive talk. Now, I like to invite Dr. Frederick Finkenstein. He is the president of International Society of Peritoneal Dialysis and is the head of nephrology at Yale New Haven Hospital. He is going to give us an update on the end-stage renal disease initiatives taken by the ISN.
Thank you very much. It's a pleasure to be here, and we're getting to the end of the meeting, which has really been fabulous. So I'm going to talk to you about this ISN End-Stage Kidney Disease Summit, for which there was a meeting in Sharjah in 2018, a follow-up meeting in Melbourne, and this process is still going on, and the thinking about this is evolving. So this was organized by David Harris, who was the past president of the ISN prior to Vivek Jha, and helped coordinate. We developed a strategy to look at the problem of end-stage kidney disease around the world and how the ISN can be helpful in supporting rational approaches to the management of end-stage renal disease. So the purpose was to understand the varying incidence and prevalent rates of end-stage kidney disease care in countries of different economic, political, and social backgrounds, and then provide guidances to the government and healthcare providers, particularly in low middle-income countries, as they expand ESKD programs and services from an economic, medical, and ethical standpoint. And one reason this meeting was held was the WHO had come to the ISN and said, what should they do? What should a rational approach be from the WHO's point of view in managing end-stage kidney disease? So the reason for that was shown here. It's estimated worldwide about 900 million patients have chronic kidney disease. Of these, about 18 million should develop end-stage kidney disease, but only 2.6 million are actually getting treated for end-stage kidney disease around the world. That means that less than 15% of patients with end-stage kidney disease are being treated, and 85% of the patients are dying. That's really the issue, and that's the stimulus for this summit meeting that was had. So 8 themes were developed, which are shown here on this slide. I'm going to run through each of these 8 themes and show you what the thinking was and where we're headed in terms of the approach to end-stage kidney disease. So let's go through them one by one. So one is data collection. And here the key was to understand the reasons for the global differences in the incidence and prevalence of end-stage kidney disease and chosen modality of ESKD therapy. So this slide shows the geographic variation in the incidence of treated end-stage kidney disease expressed per million population. And I'll show you exact numbers on this, but it's sort of interesting to look at that the highest numbers in the world are in the United States, Taiwan, Japan, Singapore, for example. Much lower incidence obviously in Africa and in Asia. And there's really a tremendous variability even inside Europe, which is shown on the lower left-hand panel here. And that, to me, remains one of the mysteries that really needs further explanation, this varying incidence, even in high-income countries. And I'll talk about that more in a minute. So this shows what the prevalent rates are per million population of treated end-stage kidney disease from high-income countries, upper-middle-income countries, low-middle-income countries, and low-income countries. And obviously the numbers drop off as you go down from high-income to low-income countries. But what's particularly striking is a real drop in PD, which drops to 0 when you get to low-income countries, and the marked drop in transplantation. And the reason this is so important is that transplant is clearly the best treatment and the cheapest treatment for end-stage kidney disease. The next cheapest is PD, and the simplest would be PD, but yet these numbers drop off dramatically as the income rate of countries really drops. And that is a huge problem that the ISN is really trying to address, and we're hoping the WHO gets involved with that as well. So again, looking at the exact numbers, and I showed this slide earlier, this shows the incident rate for end-stage kidney disease per million population. But this is not dialysis now. This includes transplantation. And you see these tremendous variations that occur, even amongst high-income countries. And again, to me, this is just fascinating. The US is twice the rates of Canada, 3 times the rate of the UK and Australia, for example. And then as the income level of the country goes down, the treated patients drops dramatically as well. Russia always remains an interesting number to me, as the numbers are really very low in Russia. And this shows the prevalent rates, again, for end-stage kidney disease. And again, there's tremendous variation amongst countries. But what's important about this, no matter what economic level of the country you look at, the prevalent rates are increasing around the world. And I'm sure that's happening here in Pakistan as well. Governments are really trying to support end-stage kidney disease therapy as well as they can. Even in countries where the government does not support that, such as Nigeria, as an example, there's been an expansion of hemodialysis unit and an expansion of the number of patients being treated. This is a huge problem. The population is increasing. The number of people with end-stage renal disease is increasing. This is what the projections are for the end-stage renal disease incidence and prevalence in the United States, projecting through 2030. And no matter which of these curves you follow, so let's look at the top one, which is the prevalence, the curves widen out because of the uncertainty. But no matter which curve you follow, the numbers are going to be increasing dramatically for both incidence and prevalent rates. And this is going to be true everywhere you look in the world. And what's particularly striking about this shows the incident rates for end-stage renal disease by age group in the United States per million population. And again, in older people, the incident rates for end-stage renal disease is incredibly high. This emphasizes the importance of looking at conservative care measures for patients, elderly patients. What is the value of dialysis? What is the value of transplantation in this elderly population? And this was discussed very nicely in 2 talks that were given yesterday. That is an issue that really needs to be thought about and addressed by the government and policy planners and healthcare providers in these countries. And to show you why this is so important, this is where we are in 2019. This is a projection for the elderly population in the United States, population over age 65 and over age 85. We're almost at an inflection point now where the numbers are going to be increasing dramatically. Develop strategies to dealing with the elderly population is absolutely critically important. So this shows the prevalent rates for dialysis now, not excluding transplantation. And I've shown here, if you look at the numbers on the left-hand panel, what I showed you before for end-stage kidneys and dialysis. This variation reflects the varying transplant rates in different countries. And this is really a critically important number. So look at the tremendous variation in transplant rates, which I'm going to show you on the next slide now, around the world. This is again expressed per million population. So the countries with the highest prevalence rates, such as Japan and Taiwan, have extremely low transplant rates, whereas countries like the US, which is shown here, or the UK, have much higher transplant rates. Remember, transplantation is the cheapest and the most effective way to treat patients with end-stage kidney disease. Developing effective transplant programs is absolutely essential, and expanding them really as much as you can. But this gives you an idea of what the numbers should be like per million population and what achievable goals are. To do this, though, you need both living-related donor transplants and deceased donor transplants. And I guess there are no deceased donor transplants in Pakistan now, right? So developing the legislation to support such a program is really essential. We're dealing with an older population, an increasing incidence of end-stage kidney disease. This is really a crucial thing that really needs to be developed. Now, one explanation for the varying rates, which you see in end-stage kidney disease, I've really summarized in this slide very nicely. So the countries in red are the US, Japan, Taiwan, and Singapore. And the countries in blue are other European countries in Australia and New Zealand. And this shows the prevalence of renal replacement therapy by age. And you see there's tremendous splits that are occurring once you get over the age of 60. And this is probably the major explanation for the varying incidence and prevalent rates in the high-income countries, the approach to patients who are elderly. It is absolutely essential that this be addressed as the population is aging. And I guess the 2 talks yesterday dealing with this were really terrific and something that really needs to be thought about. So, the distribution of therapy is shown here, and I showed this in my talk earlier this morning. I won't go over this in detail, just to show you briefly again that hemodialysis is far and away the most widely used treatment. PD utilization varies widely, and in fact, you can get 80% of the patients with end-stage kidney disease requiring dialysis on PD, and that's the experience in Hong Kong, the experience in Thailand, and the experience in Mexico, as we discussed earlier this morning. But again, PD therapy really should be cheaper, and that's one of the themes of the ISN Summit, and I'll mention that in just a minute. So the second theme was advocacy, developing an approach to advocate for integrated end-stage kidney disease care, particularly in low and middle-income countries. And this requires a prioritization of publicly funded preventative care and rational coordination of end-stage kidney disease care. So this summarizes an approach, the way we should think about the approach. First, you need to identify patients with chronic kidney disease, and then try to prevent the development of chronic kidney disease. Look at risk factors for chronic kidney disease and try to prevent them. And there's this fabulous data coming out now, I think, which is changing the whole landscape of end-stage kidney disease on the newer treatments to prevent the chronic kidney disease from developing, such as the use of SGLT2 inhibitors in diabetes. They clearly slow down the progression of chronic kidney disease and reduce cardiovascular mortality rates. Those drugs are really transforming the way we think about our approach to chronic kidney disease. Patients with chronic kidney disease want to slow the progression, prevent complications. And then if patients develop end-stage kidney disease, decide if they should get treated for end-stage kidney disease with dialysis, transplantation, or whether they should be put into a conservative care pathway. And again, the conservative care pathway was very, very nicely discussed yesterday, and it's essential that we build that into our thinking about the management of end-stage kidney disease. So interventions to slow or prevent progression of kidney disease are absolutely essential. We need to develop effective, cost-efficient ways for the prevention and management of diabetes and vascular disease that can be integrated with other healthcare programs. So working with endocrinology, working with cardiology to develop strategies to reduce the complication rate and slow the progression. And that is, again, absolutely essential now as we get better and better at reducing cardiovascular risk and reducing the progression of diabetic-related kidney disease with these newer drugs that are being used now. Develop supportive care and comprehensive conservative care management programs to minimize the burden of serious health-related suffering. Transplantation, as I mentioned, is the best and cheapest way to manage, expanding transplant programs. And then, in terms of dialysis, expanding PD programs. The outcomes are similar to HD. They should be more cost-effective. They are more cost-effective if you can get solutions at a reduced price, which we've already discussed, and you can do that here in Pakistan. So PD treatment should really grow here. Third theme is education and training. This is developing locally appropriate strategies to enhance the healthcare workforce capacity. First, you need to collect accurate information about the number, competence, knowledge, and distribution of the existing workforce. What's the role of technicians? What's the role of nurses? That was very, very nicely discussed yesterday in the integrated program which was had, and the talk that was just done next door just earlier this morning. You need to evaluate, though, the available education and training programs, perform a needs assessment by identifying the barriers and facilitating factors that inform the development of appropriate training modules and provide ongoing education for the workforce. And then estimate the workforce and educational needs to support the expansion of end-stage kidney disease services. What role do technicians play? How can we expand their role? How do we expand the nurse's role to manage patients? And to do this, we need to think creatively about solving this problem. Telemedicine, training technicians, electronic training and support. So a couple examples of how this is happening, just to mention. One in Kenya now. Kenya decided to build dialysis units in every state in the country, of which there are 47 of them. 47 dialysis units are being built. There are about 8 nephrologists in the country. How are these going to be staffed? How are the people going to be trained to support them? So they're coming up with telemedicine support things that nephrologists in Nairobi are going to be supporting the operation of the dialysis units, which will be run by just general internists, for example, with a focus on telemedicine. Technicians will be trained. They're going to develop electronic training and support programs for these individual facilities. So this is a very interesting and clever way to expand the workforce using newer technologies. The refugee crisis in the Middle East is an interesting one. You know, if you follow what happened in Syria and Iraq, how is dialysis going to be provided? How are transplant patients going to be supported given the crisis that had gone on in those countries? So there was some interesting work that was done by expatriate nephrologists working in Europe and working in the United States, where they were running dialysis units simply with technicians in the northern part of Syria, supported by telemedicine communication with physicians in Europe and the US. So you can use telemedicine very effectively. It's an interesting way to expand your workforce and provide, you know, a reasonable level of care that can support patients in difficult times. But in countries where you have, and Pakistan will be one, where, you know, developing nephrologists all around the country is going to be impossible probably, and given the difficulties in traveling around Pakistan and the mountainous regions, thinking of using telemedicine creatively is a way to expand the workforce utilization and provide support. So financing and funding models. We need to develop strategies and funding models to ensure equitable and integrated end-stage renal disease care. Now, there are no guidelines you can provide for this, but each country or region within a country needs to select the amount of end-stage kidney disease funding as a proportion of the overall healthcare budget. How that should be done is challenging. In the US now, it's estimated that about Medicare, the CMS, which supports dialysis, 8% of Medicare, 8 or 9% of Medicare expenses go to support end-stage kidney disease, which is less than 1% of the Medicare-supported population. Is that right? Is that the way the money should be spent? Those are the issues that we need to talk about, because these issues are going to get more and more striking with time as the end-stage kidney disease population ages. There needs to be locally acceptable rationing criteria with transparent methods for their application, and these need to be developed. The general principles that are related to financing of healthcare can be applied to dialysis, optimal use of resources, making the services available in an equitable manner to all, and oversight of healthcare delivery. And I want to give you some examples because to me this is really critically important. So in the United States, large dialysis organizations dominate care. 90% of care is provided by private companies that trade on the stock exchange. How do we make sure that these companies are providing adequate care and not increasing their profit margin by compromising care? You have to have essentially government regulation and oversight, and that's what's happened in the U.S. But that is absolutely essentially that have to be built into your programs. Botswana and South Africa have developed these public-private partnerships to enable the expansion of care. In other words, the governments don't have the funding to build hemodialysis units. The hemo units are built by private companies, which then develop contracts with the government to provide care at predetermined fee structures. And that, most people feel in South Africa, has actually been an effective way to expand care. South Africa, though, has already also decided to provide funding for dialysis care only for those patients who are transplant candidates. If you're not a transplant candidate, the government will not pay for your care. Now, one can argue, is this reasonable? Is it not reasonable? But it's not a completely unreasonable way to manage this. So people who are not transplant candidates are sent home to die, basically, because the government will not fund end-stage renal disease care. Nigeria is an example of probably the worst situation you can imagine. Here they have only private dialysis units with no government support. You can only get dialysis if you can pay for it. At the Nigerian nephrology meetings 2 years ago, they presented a slide showing the one-year mortality rate from dialysis is 99%. And it's 99% because people can only pay, they run out of money, they don't get any care, and they die. Physicians own the units, and it's a profit center for physicians. Does that make any sense? The answer is probably no. In Tanzania, the government has decided to provide support only for government employees. Once they made that decision, which was about 3 years ago, there was suddenly a marked expansion of private dialysis units developing in the country. And that's been good in a way because dialysis services has developed, but what about the non-government employees? And Kenya, I already mentioned their experience. So this obviously raises the question of ethics and why it's important to enunciate the ethical principles surrounding end-stage kidney disease care. And it's essential that this be done. This has to be done we have to take into account the equity, availability, and quality of care. And we have to clearly develop an international statement articulating core ethical principles and values to guide policy and practice in end-stage kidney disease across varying economic backgrounds and decide which types of policies make sense from an ethical point of view. And that's sort of summarized here, where you need to take into account these various factors in promoting end-stage renal disease care from an ethical standpoint. And that really, to me, is really critically important as we move forward. Dialysis. It's important to define, recommend, apply, and develop a monitoring framework for minimum and optimal safety and quality standards for both PD and HD. So there are guidelines, in the United States and the UK and Europe, for example, Australia, that have been developed that set standards at a very high level. These need to be adapted depending upon the economic resources of each country. What services are available? What medications are available? Is erythropoietin available, for example? Is intravenous iron available? So these need to be looked at within each country, and they need to look at the guidelines, but develop a standard of care which needs to be followed in the country and then needs to be implemented. And the implementation needs to either come from the government or from nephrology organizations to ensure that basic standards of care are met and maintained, whether it be water purification, dose of dialysis, safety precautions, infection controls, etc. So again, government and organizational oversight is essential. It's generally agreed that PD should be encouraged, PD first, because of simplicity and lower cost. The value of incremental dialysis and trying to preserve Residual kidney function has been a theme that's come up repeatedly at this meeting, and that's essential because it can reduce the cost. But there needs to be an ongoing assessment of outcomes and an evaluation of programs. A registry has to be developed. You need to look at outcomes, make comparisons from center to center, from region to region, to see what's going on. So let me give you an example. If you're talking about hemodialysis, do people need to be on dialysis 3 times a week? Is 2 times a week, which is the standard care I understand in Pakistan, is that acceptable? If patients are dialyzed 2 times a week, should the target be a K to V of 1.2 for each treatment? Should they be on dialysis for longer periods of time? That's a critical question, and there's no answer to that question. It really needs to be looked at. In PD, for example, we've discussed that if people have residual renal function, you can do incremental PD, 2 exchanges a day, 4, 6 days a week, give patients 1, 2, or even 3 days off. And lastly is transplantation. Clearly, transplant is the cheapest and the best way to provide end-stage kidney disease care. Transplant programs need to be expanded, but there needs to be really oversight of how these transplantation programs are offered. And then you need to have, first, legislation for organ donation and safe transplantation in all countries. For example, in Russia, there were problems with using liver-related donors where patients were accused, the government was accusing people of, taking organs from patients living. Is it fair to sell organs for transplantation? The policy which they have in Iran, for example, where the government regulates the donation of organs, and in Iran, there's no waiting list for a transplant. Everyone who wants to gets transplanted. Is that a policy that should be applied in other countries? Can that be done equitably or not? Those are the types of questions which we really need to answer. And lastly is conservative care, and we've already talked about that, so I won't go into that any further. So again, it brings us back now to where we were in the beginning. What is the role the ISN should play, the ISPD should play, the Pakistan Society of Nephrology should play in looking at this issue? And I think the key here is to identify the risk factors for chronic kidney disease and prevent it from developing. Once it develops, slow the progression. Develop rational approaches to end-stage kidney disease. And again, develop an integrated model incorporating conservative care, transplantation, PD and HD, focusing on ethical issues, finances are available, and clearly monitoring, tracking outcomes, and having clear oversight of the way end-stage kidney disease care is monitored by getting registries set up and having policies set by either government or by the Society of Nephrology of what are adequate standards of care. Thank you.
Thank you very much, Professor Frankenstein. House is open for questions, please.
So thank you so much for your talk. It's very insightful, sir. So the question I'm pretty sure that you can answer that as well. It's actually more of a comment initially that, so we've had discussions over the last 3 days regarding that what are the barriers. So sort of determined that PD isn't that expensive at all if you compare it to hemodialysis on a global scale. But the main problem that we do feel in Pakistan is the nursing care, especially when it comes to peritoneal dialysis. So my question is twofold. One, is there a figure that if I had 8 PD patients, I should have a nurse against that number? One. Number two is because the number of peritoneal dialysis patients are so low at the moment, would it be worthwhile training our hemodialysis nurses? Have you had any experience with any country, our hemodialysis nurses being trained for that? And lastly, I'm sorry, is that when we say training for peritoneal dialysis, I'm not too sure what that means. Is it fine if I sort of train them myself because I believe in PD? And if I'm okay with it, is that fine? Because the dialysis technicians program in Pakistan only teaches them hemo. Or can we use telemedicine to sort of train those nurses to become PD nurses? And are you aware of any, maybe the ISPD has modules online that we can sort of say that if you've done 6 modules, that's where you are?
Yeah,
I hope, yeah, so it's a long question, but I thought that, you know.
No, it's a
that's
good question. So I think, as Edwina had mentioned, the ISPD guidelines recommend that there be one nurse for 20 or 25 patients. I think Rory mentioned earlier that expanding his program, you can't have one nurse for 20 patients. You need more than that. Nurses in our program, nurses take call at night, for example. If patients have problems, the call goes to the nurses, not to the physicians. And you have to have nurses available, so if a patient comes who needs to be trained, you have to train them. So I think you have to have the nurses, enough nurses available to train patients when patients present, take call at night to deal with problems if patients have them. They have cloudy fluid, they're not draining. Physicians can't deal with those. You're not going to know what to do. Nurses know that much better than physicians would. So I think you need to look at what the ratios are. And again, although the guidelines say 20 to 1, I think when you get up to 100 patients, you could probably have 5 nurses. If you have 20 patients, you probably need 2 nurses. 30 patients, you probably need 3 nurses to keep your program running and be available to train. On the other hand, when you go to China, they've got these enormous peritoneal dialysis programs, 300-400 patients staffed by 4 or 5 nurses. How they do that, I don't really know. It's an interesting question, and I can't imagine how that actually happens. So the standard model in the US, I think in the UK is the same. It's about 1 nurse for 20 patients. So the training of nurses, again, there's a lot of information on the ISPD website in terms of what's important for nurses to be trained on. If nurses need training, there are fellowships you can get from the ISPD to go somewhere for 2 months or 3 months and get additional training. I think the Society of Nephrology should develop guidelines for what the nurse's role should be, what the training of nurses should be. I think that would be very helpful. That goes back to this issue of workflows. Edwina's sort of been a pioneer in developing assisted PD programs using technicians, not nurses, to go into patients' homes and set up cyclers, and they can evaluate patients, checking the blood pressure, checking the weight, for example. So the role of technicians needs to be thought about. There's a big interest in telemedicine, for example, following patients at home with telemedicine, just using smartphones to communicate back and forth. I think it's in a state of flux. You need to look at what resources you have, how much money you have, what creative ways you can support programs. Edwina, Roy, do you want to make any comments?
There is a nurse working group as part of the ISPD, and you can certainly, they have protocols, and it would certainly be worth making from somebody from Pakistan to make contact with them and say that this is something that you need here in Pakistan, and can they help? And they would be very pleased to do so.
Thank you.
Well, it seems like that, Doctor, your question was more directed toward Professor Nisar Anwar, if you are talking in the perspective of PD in Pakistan. There are, as you know, several bottlenecks regarding, let's say, the doctor's incentive. Once you do a practice in US or in European society, I am not sure about the European, but I have done in the US, there is a method of reimbursement. I am not saying that doctors are not adhering or going toward the PD because they are not being reimbursed or there is no methodology of that. But the other thing is that as the previous presenter has mentioned, that the companies are abandoning this market. We have problems for the supplies, and also as well the environment in which we are living and the cleanliness. There are many handicaps around, and I think you can catch up with Dr. Nisar in the break, and we can have the meaningful discussion on that.
I was going to come in on the previous comment, just in terms of nursing numbers and things, and I think it's right. You don't get that economy of scale with a small population. You need more staff, but it's really personality, and you need to look at personality type of your nurse, and just take your best nurse that you have right now, replace her what she's doing with someone else who's not quite as good, and give her